I always love to see that kind of data because it just makes me hopeful, right? It makes me hopeful because a lot of what we need shorter, better regimens, right? We need to find ways to do this in a better way, and I always love to hear that kind of data. So I know it's a bit data heavy, but you know, in a time where we're hearing a lot of things that make us maybe a little depressed, we are having very serious conversations about how we can do right and do better by our folks. I always find it a little bit uplifting to see that, you know, no matter how hard the struggle is, there are some new things down the road and we can do a better job. And so this next one, now how many of you have taken care of a drug-resistant TB case? So this is a really big crowd for that. Normally, like in our courses, you know, especially our intro courses, it's a lot of people who are doing LTBI work. But this was like 90% of the hands just shot up. That's fabulous. So now I really want to get you to dive in. We just did this a couple of weeks ago at the North American Region Union meeting, which of course I didn't mention. Where's Bob? He's out of the room. He is the next president-elect. Bob Horsburgh is, but I forgot to say that before. But we did a session, and Penn and Barry, Neha Shah, other folks, Chuck Daly, our old friend, were there, and we talked about this debate about whether or not we, in a high-resource, low-incidence setting, are ready to take on something that the WHO is now recommending across the world we should be using with drug-resistant TB, but with many different caveats. So just to kind of get your heads going on this and thinking, what am I going to do in my clinic, or what might I do in the next year or so? We, of course, are going to tap someone like Penn and Barry to come on up. You all know Penn from the State TB Department of Health. He's the surveillance chief, but he's also been with the MDR service for forever, it feels like, in a good way, in the best way, right? So he's going to walk us through thinking about the parameters for use in the shorter course regimen for drug-resistant TB. And then I think he's going to quiz you all on, like, how do you feel about that? You ready? Nope. I'm hearing nope. Well, let's just see how you feel at the end, and how can we collectively move the needle. You go ahead. Come on. Come on up. He keeps going. Yeah. All right. So, yep. Really, I'll give up the mic.
Okay, thank you very much. So I think a fewer graphs in my talk today if you were here yesterday. And I think Lisa gave a great introduction to, I think, where we are right now in California anyway, but I think in the United States about thinking about use of this regimen. So I should say that most of my slides came from Chuck Daly. So I'm going to be talking this morning about the WHO treatment guidelines for drug-resistant tuberculosis, the revision that came out in 2016. I'm obviously going to focus on the short course regimen, but I'll start by talking about the more conventional treatment approach as recommended in these guidelines. I will show some study data that WHO used to make these recommendations, and then finish up talking about some of the implications of those data and this regimen for use of the regimen potentially in the United States and California. So if you've looked at these guidelines, you may have noticed that they have regrouped the MDR-TB drug. So instead of the way that they are somewhat grouped in the survival guide, they have changed some things around. So chiefly, Group A is now the fluoroquinolones. Group B are the injectables. Group C is where a lot of the changes occurred. So previously, this consisted of ethionamide, cycloserine, and PAS. You can see that clofazimine has been quote-unquote promoted to this group. Linezolid also has been promoted to this group, which does, I think, reflect how we think about and use linezolid. PAS has been moved down to Group D, and Group D now consists of the first-line drugs, the newer drugs, bedaquiline and delamanid, as well as PAS and the beta-lactams. So what WHO recommends is this algorithm for building an MDR regimen. If you're building a conventional regimen, choosing 1 fluoroquinolone, 1 second-line injectable, 2 from Group C, so that's the ethionamide, cycloserine, clofazimine, or linezolid. And then if you still don't have at least 5 likely effective drugs at that point, the universal recommendation globally is to add pyrazinamide. You can use the other first-line drugs like ethambutol if there's susceptibility, and then high-dose INH is in this group as well. Now, I would say that this regrouping has caused a lot of, I would say, discussion within our team in California. I think what we actually do probably is still better reflected by what's in the survival guide, but this, particularly how we use clofazimine, how we use linezolid, and how we use a high-dose INH, this has spurred a lot of discussion and thought about that. So in terms of duration, these recommendations from WHO did not change in this version of the guidelines. They suggest an intensive phase of at least 8 months with a continuation or a total duration of at least 20 months. Now, for the survival guide, and when we got together and polled experts in the United States who are using MDR regimens, what was pretty universally, I think, the consensus was that we use culture conversion to set duration of therapy, and so in general what we will do is 6 months after culture conversion for the intensive phase and 18 to 24 months, but more commonly 18 months after culture conversion for total duration. And I think that's pretty consistent actually with this duration, where often you may not have culture conversion internationally. So these are global outcome data for MDR-TB from the WHO report. You can see that this line is 50%, and in green is treatment success. So really not good outcomes globally at all in terms of cure success for MDR cases. Now this is 2007 to 2012, but I present this because really there's a need, a large need for improving the treatment success, and so this is where a lot of the excitement about the short course regimen comes in. So published in 2010, it was a observational study done in Bangladesh where they actually did serial cohorts of MDR patients. And they were very rational in terms of trying out a regimen, making a switch, looking to see what treatment success was, making another switch serially until they arrived at a regimen that they felt, and in fact, in their data had treatment success of almost 90%. So compared to the 50% that I just showed you, this is dramatic, particularly when you see that this is a treatment course of 9 to 12 months. So the alphabet soup there on this table, this final regimen includes kanamycin, clofazimine, gadifloxacin, ethambutol, high-dose INH, PZA, and prothionamide in the intensive phase. Let me go over these regimens in this figure because I think it helps to show this, this kind of rational progression that this group took and how they arrived at that complicated regimen. So furthest on the left, regimen 1 and 2 were standard ofloxacin-based regimens with prothionamide and INH throughout, so that had a success rate of about 70%. Now, in regimen number 3, they took out INH. So this is MDR, but they took out INH, and they saw a fall in the success rate to below 60% when they took INH out of the regimen. And so they quickly put INH back in the regimen for regimen number 4. And saw it come back up to a higher success level. They added clofazimine between regimen 4 and regimen 5 and saw that increase in success when they added clofazimine. Everything else in the regimen was the same. They got above 80% success. And then when they changed the fluoroquinolone from ofloxacin to gadifloxacin, and a high-dose gadifloxacin, they were able to achieve that 87% success rate. So not a randomized control trial, but kind of rational serial cohorts with this short regimen, and achieved really good results. So more details on that regimen: 82% cure, 5% they didn't have the data for cure, but completed, 5% deaths, very few failures and defaults. So a lot of excitement about this regimen. And then the regimen started to be used with additional data collected. That's how WHO began to talk about the regimen after publication of those data. And these countries in green began to use the short course regimen while following closely their under operational research conditions. And the data from these countries, again, also not randomized controlled trial data. Dr. Horsberg talked about those data should be coming soon, but in the meantime, WHO decided to look at these data to see if they could recommend the regimen. So this slide is complicated, but I think just I wanted to summarize that because these data are coming from multiple countries with their various levels of information that was available to the group that was writing these recommendations. So some data, there was data on relapse at least 2 years after treatment, but in most of the countries there was not. There were different ways that MDR-TB was confirmed in these cohorts. In many of the cohorts, large proportions of patients were actually excluded, seemed to be eligible, but then were excluded for various reasons. And so you can see in the bottom row there, most of the data, a lot of the data, 500 or so of the 1,100 patients came from the Bangladesh study that I talked about already. The second highest was a conglomeration of sub-Saharan African countries sponsored by the Union. So just to say that this analysis involved a lot of pulling together of data from various settings. Additionally, there was some difference in the availability of data on extensive disease. Now, we talked a little bit about how predictive is extensive disease. The vast majority of patients in most of these cohorts were smear positive, did not have information on chest x-ray findings for most of the cohorts, but where that information was available, it was a minority of patients that had cavitary disease. And you can see in the Bangladesh regimen, it was about 20% had a cavity on chest x-ray. Now, the other thing that I found to be interesting coming out of these data was this. So there was actually quite a bit of resistance in these cohorts to ethambutol and PZA. You can see 70% in the cohorts where this information was available of ethambutol. PZA lower in Bangladesh, but higher in some of the other countries. And I will show you the regimen again, but PZA and ethambutol are both included in the regimen that seem to have such good outcomes. So here is treatment success when all these data are combined. So looking at all cases, 93% had a cure or completed. On the right are data from a individual patient data meta-analysis looking at more conventional MDR-TB regimen. And you can see there 78% success. Now generally those cohorts extend further back in time, but this seemed to be better than the outcome in the conventional arm. Now when you divide and look at the outcome based on individual fluoroquinolone or PZA susceptibility, you can see that if both were susceptible, outcomes were quite good, 97%. If you had PZA resistance, that dropped to 88%. Fluoroquinolone resistance dropped to 80%, and if you're resistant to both, patients with that pattern had 68% success. Now you see that it declines, but in each case, at least with this comparison with the conventional MDR group, it had better success than the conventional treatment. Well, so these data led WHO to recommend the shorter course regimen. And how they talk about it is in patients with rifampin-resistant or MDR-TB who have not been treated with a second-line drug, and in whom resistance to fluoroquinolones and second-line injectable agents has been excluded or is considered to be highly unlikely. So this is the language in the WHO recommendations. I'll talk a little bit about. We're actually kind of the flip side of this situation where we actually don't suffer maybe from a lack of information. In some ways, it makes it more complicated because we have more information on drugs and their susceptibility. They say a shorter MDR regimen of 9 to 12 months may be used instead of a conventional regimen, conditional recommendation, very low certainty of the evidence, which is, I think, all of these recommendations given that level. So the WHO recommendation goes on to say that in addition to ensuring that the strain is susceptible to fluoroquinolone and a second-line injectable, they say do not use this regimen for strains with resistance to one or more of the drugs in the regimen. So this is where I think we have challenges in terms of the number of patients that we see here that may be eligible for this regimen. They're also very explicit that this was a regimen that was a standardized regimen, and so altering the regimen, as we like to do all the time with our MDR patients, we're constantly switching drugs in and out, but the recommendations do not recommend doing this, with the exception of you can substitute moxifloxacin for gadifloxacin. That's good because gadifloxacin is not available. Similarly, ethionamide for prothionamide, another second-line injectable for kanamycin, which was the drug in most of the cohorts. And of course, the intensive phase could be prolonged to 6 months if there's no smear conversion. So this is how they recommended the regimen. This is a schematic. So those 7 drugs in that alphabet soup you saw in the prior table for 4 to 6 months, depending on smear conversion. It includes moxifloxacin, ethambutol, pyrazinamide, and clofazimine throughout. So this is why, if you look at this regimen, this is why those rates of resistance to ethambutol and PZA, I think, are so interesting to think about. Why did this regimen work so well? Well, fluoroquinolone we know works well. Clofazimine, Dr. Horsberg talked a little bit about, and certainly in the Bangladesh initial study, there seemed to be a large increase in success. But without ethambutol and pyrazinamide, you'd be talking about a 2 or 3 drug regimen during that continuation phase. So going on to the other drugs in the initial phase, ethionamide, high-dose isoniazid, and a second-line injectable for those 4 to 5 months. These are the drug doses that are recommended by WHO in the weight-based bands. I show this because there's been some discussion about what does high-dose fluoroquinolone mean, what does high-dose isoniazid mean, and so you can see here that isoniazid in particular, the highest weight band here has 600 milligrams a day of isoniazid, which is lower than what I think sometimes when we have used high-dose isoniazid, we've used 900 milligrams 3 times a week or other quote-unquote high-dose isoniazid. So there's some discussion about whether this is really high-dose isoniazid. I think it's higher-dose isoniazid. And similarly, the fluoroquinolone. So moxifloxacin standard dose is 400 milligrams a day. This can go up to 800 milligrams per day. So here's the fact sheet from WHO to put their recommendations into an easier to follow algorithm. So if any of these criteria are present, then this patient is not eligible according to these guidelines for the short course regimen. So confirmed resistance or suspected ineffectiveness to a medicine in the regimen except for isoniazid. Exposure to a second-line drug that's in the regimen, intolerance to one of the medicines, pregnancy is an exclusion, extrapulmonary disease is an exclusion here. But note that they do recommend this regimen for children, or can be used for children. And the last one, a programmatic one, is if you are in a setting where you can't get one of the medicines in the shorter course regimen, you shouldn't use it. And then you can start the shorter regimen, and if any contraindication shows up, such as intolerance, interruption, or new susceptibility results, you can move to the more conventional regimen. Well, I think internationally, I showed already that a lot of the excitement around this regimen was the great success rates that were able to be achieved with the regimen, almost 90% success. So I think when thinking about how and if to use this regimen in our setting, looking at our success rates are important. So I showed this slide yesterday if you were here. Since 2009, there are 195 cases of MDR in California. About 50 remain on treatment. 11 moved out of the United States, leaving 132 whose outcomes are in the bottom bar there. So about 90% cure or completion of these MDR cases. We did have a few deaths and some failures, but pretty good success rates on par with these outcomes with the short course regimen. So I think in thinking about how to use it or whether to use it here, being able to cure or complete treatment is really not the driving factor behind wanting to, or not the advantage behind using it here, but really shortening from an 18 to 24 month grueling regimen. I showed yesterday the almost 15,000 pills we ask our patients to take during that time, to really shortening it to about half, and that is the advantage. A limitation is that with full drug susceptibility test results available, many patients aren't eligible for the regimen. So these are data that were published in a letter from cohorts of MDR patients in Europe. So the numbers in the table show the percent of resistance to each drug. You can see 33% overall resistance to fluoroquinolones in these cohorts, 67% resistance to PZA. So actually similar to the cohorts of patients that WHO used to make the recommendation. And when you shake that all out, only 8% of patients, of 600 patients in these cohorts would be eligible for the short course regimen in Europe. So we went ahead and did a similar look at our data, and those are shown here. We had 171 patients with full drug susceptibility test results. We had a lower rate of fluoroquinolone resistance, only 9% in this group, but still quite a bit of ethambutol and PZA resistance. And we had about 15% of patients, just by these criteria, seem to be eligible for the short course regimen. Now, one thing I haven't talked about, but which we went ahead and looked at here, is that if you said, okay, well, if you allow for resistance to ethionamide, but say that you're overcoming some of that resistance by using high dose INH here, and you allow for ethionamide resistance as well, we could treat an additional 10 patients or a few more percent with this regimen if we were comfortable using those as criteria. So, I've talked a little bit already about some of the barriers and some of the discussion points that we've had around use of this regimen. One, clofazimine is available to us. It's difficult. It requires IND, some FDA applications. It requires patient signing consent to get clofazimine. It is available, but it's not easy. I already talked about we have full drug susceptibility test information, so kind of in a paradox, it may make this regimen less available because fewer of our patients will qualify. I think there's some discomfort around use of a standardized regimen when we are so used to individualizing our regimens and changing the regimens over and over again when patients don't tolerate drugs, that there, I think, is some discomfort and some nervousness about embarking on a regimen where really some of that freedom seems to be restricted by WHO recommendations. And then my last bullet, I'm not sure exactly how to characterize this, except that you look at the regimen, they are not new drugs. They're the 4 drugs that are in the continuation phase. There's high levels of resistance to both in the original cohort, and it raises the question of why does this regimen work? So when we discussed this in Vancouver, there was a range of thoughts about use of the regimen. Some folks on the panel were not as interested in using it, wanted to wait for the randomized control trial data to come out. Others were interested. And I would say on this panel of persons from the United States and Canada, who see a bulk of or consult on a bulk of the MDR patients in North America, there was one patient who had been started on the short course regimen that was in Canada, had a bump in LFTs and had been stopped. Nevertheless, I mean, I think that all of you that raised your hand saying you had treated MDR-TB, you know how difficult it is, and wow, wouldn't it be great to do that for 9 months instead of 18 or 24? Well, let me finish with a case and ask you the question: would you use the short course regimen in a patient like this? So this is a middle-aged man from the Philippines who sought care for cough, fatigue, decreased appetite for a month. Past medical history, just gout, no prior history of TB treatment. His chest x-ray had patchy infiltrate in the anterior left upper lobe, but no calcification, no cavitation, excuse me. Smear positive, pretty robustly smear positive, 3 to 4 plus. And with molecular susceptibility results shown here, mutation in RPOB and INHA, but no mutations conferring resistance to ethambutol, to fluoroquinolones, to injectables, or to PZA. So just to summarize those results, we likely have resistance to rifampin, resistance to INH probably at low level, susceptibility to ethambutol, PZA, fluoroquinolone, and second-line injectables. And of course, this doesn't give us too much information on ethionamide and clofazimine, although INHA mutation does often confer 70 to 80% of the time resistance to ethionamide. So this is a question, after hearing these data, would you recommend or feel comfortable with using the short course regimen in a patient like this in California? I don't know if anybody wants to raise their hands. Who would feel comfortable? Couple people. Many of the members of the MDR service. Dr. Horsberg, good. So like I said, I mean, I think these cases do fit, I think, criteria from WHO. Cases similar to this. We have not used the short course regimen, so I'm here giving an hour-long talk on a regimen that I have never personally recommended, but because I think we're excited about it. We would, and I think that after discussion at various venues, we would like to use this in patients that fit the WHO criteria, maybe have not extensive disease, limited to pulmonary disease, with molecular results that show just rifampin INH resistance and no other resistance without prior second-line drug exposure. Now, during the session in Vancouver, it was pointed out that, if I can go back to the regimen, which I always have to go back to, it was pointed out that the 7-drug regimen is actually a fine regimen, at least according to the current WHO guidelines for MDR-TB. So you really, if you start the regimen, you're really not losing anything. It's not like you're heading down a pathway that you can't come back from. Now, admittedly, this isn't the regimen that we would probably normally recommend. We would usually include linezolid. We would normally not start out with clofazimine in most patients, but so we could start and then switch to the conventional, more conventional regimen later if there are problems. I think I will stop there and entertain any questions. I'm particularly interested in anybody who didn't raise their hand, why you wouldn't feel comfortable. I think this, hopefully I've reflected that this is an ongoing and active discussion and debate.
I told Penn I'd come up here with them and egg people on to come on up and give their thoughts, but go ahead.
Hi, Penn and Cameron Kaiser again. So specifically for the case, and then I have one other question after that, especially since he had a history of gout, wouldn't you be concerned about the PZA dose in that case? Yeah, so it's a good point. I mean, we don't always just avoid PZA because of gout from the beginning, but it may be a reason why he might not. Higher dose too. So PZA is not necessarily a higher dose, but it is used throughout the regimen, so not like the standard regimen. So yeah, I mean, I think it's a consideration. I mean, I think I would start out with PZA and probably feel comfortable with that, but may not tolerate it throughout. Well, that actually leads me to the second question. For a lot of the patients that we have, if I had to be on 7 drugs for 5 months, I think I'd puke my brains out. I would be very concerned about tolerance in a lot of our patients for that reason. I mean, I'm fighting with tolerance issues in a number of them who aren't even MDR yet, and I have more options, but it's harder. For this one, I would be very concerned that most patients would not be able to get even close to 5 months with the amount that they're on simultaneously. That's more of an observation than a question, but I would be very concerned about it. Sure. I mean, I think that you may be switching out some, you're using more drugs, a few more drugs at the beginning. I mean, it's not atypical for MDR patients to be on 6 drugs and sometimes 7 for a brief period at the beginning. So not too different from that. And if you exchange that for a 9-month shorter regimen,
you know, you have to weigh the risks and benefits. But yeah, pill burden and number of drugs is a concern. That's a concern with all of our regimens, I think.
But an even shorter period of injectable as well.
True, that is
Yeah, it is. Yeah.
Yeah.
It's
Yeah,
it's
so
7 days per week. I'm sorry.
So yeah, 7 days a week of the injectable for the first 4 months, but it's 4 months instead of, you know, 6 to 8 months.
Yeah, so to further your concept that sometimes we might have too much data, what happens when one lab says PCA susceptible and another says PCA resistant?
Yeah, well, right. So again, I mean, I think these are the downsides of having the information that we have. I mean, I think what I put on the slide was based on PNCA sequencing from CDC, which I think there's some emerging evidence may be better than our phenotypic testing, so I would actually feel pretty comfortable with that. Of course, when inevitably you start the short course regimen based on PNCA and then PZA comes back resistant from one lab later, I think that would be a decision point. Do we still feel comfortable with this regimen or not? In the back of my mind, I would think about that graph that I showed showing that 70% of the patients that this recommendation is based on were PZA resistant.
So just also as a follow-up to that question, the WHO says because EMD and PZA are so unreliable, especially internationally, to ignore them. So that kind of poses another problem for using it here.
Luis?
So in terms of being comfortable using a short course regimen, if you said it was okay, then I would be comfortable.
That's very kind, Luis.
But just in terms of getting clofazimine, how long does that process usually take? I mean, is that kind of feasible to do if you've got someone who's waiting to go on treatment?
Well, so right now we at the state maintain an ongoing IRB so that we don't have to start from scratch. Jurisdictions don't have to start from scratch to get access to clofazimine. It still does take some time, I would say on the order of probably 2 weeks to get it, but I think that is I think that's within the realm of making it possible and not a complete barrier to using this regimen. So additional work, some delay, but I think it's possible. Edie.
Good morning, Pennon. My name is Edie Letterman from Immigration and Customs Enforcement. So I have a reply to the case as well as a follow-on question. For my situation, I never know how long someone's going to be in our custody. And so with a drug like clofazimine, where we may have to transfer an IND or drug, I have some hesitation using that. We did treat that patient with bedaquiline a few years ago, but that took a lot of very close coordination. So my follow-on question is regarding the cost. And so I'm wondering if you have any information on whether the shorter course will be cheaper than the longer course. And secondly, if you have any information regarding perhaps current or future grants or subsidies that might help our health departments not go bankrupt when we have to treat our MDR and MDR-TB cases.
So thank you. So in answer to the first, yes, so this regimen does end up being cheaper. I mean, you can see that there are no new drugs in the regimen and you're treating for substantially less amount of time. You know, even though clofazimine is hard to get, when you do get it, it's free, so that helps. So yes, in terms of cost, it is a lower cost regimen. I think there have been some analyses globally about that if that cost savings is put into back into the MDR treatment program, that you actually, that's another advantage internationally, is you're able to treat many more MDR patients with a fixed amount of money. I mean, in terms of paying and the increased cost involved in treating MDR patients, I mean, you're right. Studies show we estimate that on average, 5 times more cost for treating the average MDR patient a lot of that goes to hospitalization, but it can be expensive for local programs, particularly for patients that don't have other coverage or payment for their patients. I mean, I will say that on the public health side, MDR is in the funding formula for the public health programs, and it's weighed pretty heavily in terms of the formula, but that money doesn't cover the cost of drugs and hospitalization and other things like that.
Thank you.
Gisela.
Gisela Schechter. I'm very enthusiastic about the regimen for a couple of reasons. One is compared to meta-analyses that have been done in the past that came up with the 8 months of intensive and 20 months for the total duration, I think we are using better quinolones now. Levofloxacin and moxifloxacin are significantly better than the ofloxacin, which was used in these other longer regimens. And I think we're better at controlling side effects from these drugs as well. We have stronger antiemetic medications and so on. So I think that barrier can be overcome. And I'm enthusiastic because we've had pretty good success. There are some patients who just can't tolerate an MDR regimen, but we found when we've had to stop treatment at, let's say, 12 months after culture conversion as opposed to 18, outcomes have been equally good. We have not had failures or relapses at that point. I think with the current drugs that we use, we probably are treating longer than we need to. And with this more intensive initial phase, I think we're going to get there. I'm also very enthusiastic that clofazimine has found its way back into the regimen, because being an oldster, in the 80s and 70s, I have to admit too, but 80s, we used for MDR-TB, we did not have quinolones initially at all, but we had good treatment success and did use clofazimine quite frequently. So I'm very familiar with the drug and I've been very satisfied with it. So I think weighing all things, 9 months is so much better than 18 months that I think we just need to get our feet wet and give it a try.
Thank you. Yeah, I mean, I think it is worth reflecting how we got to where we are today, right, which is not based on other randomized trials. It's basically been based on adding new drugs to an already large regimen as they come out. And so it may be that the drugs that we've added have been good, the later generation fluoroquinolones, and we no longer need to treat the way that we have in the past. And maybe this is evidence of that. Yeah.
Sheila from Las Vegas. So if this course fails, raining on your parade, but if this course fails, can you continue the drugs, or would you?
So in an individual patient, if you start this short course regimen and it doesn't work, I mean, if it's microbiologic treatment failure, then you obviously have to worry about what additional resistance might have developed on this regimen. I mean, hopefully, if you're following the recommendations and there's no resistance, or you don't know resistance to any of these drugs, that may be unlikely. But yeah, you're using an injectable fluoroquinolone here, so that would be of concern. I think it would be unlikely for us to see that, but certainly we could. If you're talking about intolerance or having to change the regimen otherwise, I mean, I think, like I said, we could transition to a more kind of conventional MDR regimen.
Groups that use this regimen had criteria to extend, and even the WHO, out to 12 months if you had evidence of kind of slow response. And, you know, really, I think it was that eye-opener when we were talking about it in Vancouver that, right, you can really start with this, then get your data back and decide, still count the time, right? And decide, oh no, I'm going to feel safer with an individualized regimen based on now I have my full phenotypic DST on top of this, or you see how a patient does. So you're not losing ground. But it's, I do miss my linazolid, you know, or I miss, you know, our good drugs up front. And so that's what it'll be curious to see how, like, the next arm of STREAM trial does, throwing bedaquiline in. taking out the injectable, wouldn't that be fabulous? And still having a shorter time period. And I want us to just stop and think about what happens to the poor guy or gal who has this drug-resistant TB, what happens through their life during this period. And if you could have that, I mean, I know the first 4 months of taking a lot of pills, which it's not going to be that many more pills than we already give, and it's going to be shorter time having to get injectables, but it's 7 days a week. But getting back to their real life in half the time, it's incentive to really try to rethink how we're doing. And I know there's more people standing up, but I'm thinking too, if Bob wants to, I would love to hear your thoughts on this. And Lisa from, Heartland is like the heart of a lot of our MDR care in the country. And Barbara Seaworth was on the panel, but Lisa's right there, right beside her. So just, any thoughts on how you think you might go forward in advising and using this. But let's get to the folks who are at the mics. But come on up, you guys. Or anyone from all of you? Anyone from all of you? I thought Caitlin was thinking of coming. I think she couldn't. She must not have been able to make it. But
So if the branch is excited about this regimen, couldn't the branch help us get clofazimine easier? Instead of each county having to do an individual, I forget the terminology, but instead of having each county having to do an individual and meet for the IRB, can't the state do a group and then and
Yes.
meet their own? Yeah.
Yes, so we have that. So that's the situation now. So we maintain an IRB at the state level that can be used by local programs. So you don't have to go to your IRB. There's still paperwork, it's still additional work, but it doesn't involve starting that up all on your own.
they are still your best friends. These guys are good.
We try.
Neha Shah at the State TB program, and I'm excited about the short course. I feel like we need a support group, maybe it's just the two of us, or three of us, Penn, I'm including you. So that the individual patient who, I will admit, I had recommended the short course on that patient. One of the things that I had a hard time with was the INHA mutation because we thought they would probably be resistant to ethionamide. So this is a little bit of an ethical issue. I'm going to give this patient a drug that I think he's probably not going to be susceptible to, and it's not a very well tolerated drug. And so we kind of ran into that problem of what you do in that situation. As Pennon pointed out, there was a lot of resistance to these drugs in the original trial, and part of the reason for the high-dose INH and ethionamide was knowing full well one of those was probably not going to work. And so then I was kind of left with the question of, well, then do I take that drug out because I do know it's not going to work? Or is there something really wacky about this combination of drugs that I just need to give them all and they'll magically work? So that's kind of been my personal dilemma when I've come across these patients. Someone is going to be, they're going to be resistant to one of those drugs, and what to do in that situation. And maybe you just give it because there's some magic in the 7 drugs, but it's a little bit hard to want to give a patient something that's going to make them kind of vomit.
Well, I guess that's a question. Bob is right behind you. I mean, are there more thoughts about synergy between the drugs? Or I know the discussion in Vancouver was, maybe, especially with extensive disease, you can have mixed populations, and it's just this high kill of all the populations at the beginning because you're using lots of drugs. So just like your curve, if we throw a lot at the beginning, are we knocking down maybe mixed populations and then you don't need longer after that?
I think more drugs are better when they're all, when the bugs are susceptible to them. I think that if you have a drug that's not susceptible, you have good reliable data that the bug is not susceptible, I think it makes no sense to use that. I would agree with Neha that when you get your results back, you'll probably want either high-dose INH or ethionamide and not both. But then the regimen is not as strong. And the data are that, when particular drugs are not able to be used, it may not be a good regimen. The fluoroquinolones are, if it's resistant to fluoroquinolones, you don't use this. If you don't know that, you can start this regimen, but then if you find out that you're resistant to fluoroquinolone, you've got to add linazolid or something, you've got to do something. And with regard to PZA, my take on it is that I mean, if you have access to PZA susceptibility and you can get the isolate sequenced by CTC and it's resistant, then don't continue using it and think about adding something else to strengthen the regimen. But then you're in uncharted territory. So you're not going to know that at the beginning. And I'm like Kisela, I think this is really good. We should be doing it, and yet we will find out that some patients aren't the right patients for it, and we're going to have to alter what we do. I particularly like not using more than 4 months of the injectable. That's just, you really start to get into much more problems with hearing loss after the 4th month. And you're not going to avoid them completely by having the shorter, but that's where so I think it's worth starting and then watching carefully. In other words, don't just start it and say, oh, great, I'm done. You have to then monitor really carefully what's going on.
You just collectively, when you said that about the injectables, there were these head nods. The whole room kind of went like this.
I mean, this is, we all have the same experience, so we all came to the same conclusion.
So I have to channel my inner Barbara Seaworth to answer the question. Because I think, and to mirror what Bob said, it's all fun and games until we get shot in the backside. So definitely decreasing the injectables is a huge thing. I think, I guess in listening to Barbara speak and her concerns, she was really excited about a shorter course. Initially when the thought first came out and there was some success with the regimen, she was presenting them in her talks and she was really excited. But I think when she looked at the patients that she consults on, especially the ones like in the binational program, there were only about like maybe 20% of patients who actually qualified for the regimen. And so then her enthusiasm kind of waned a little, but I gave her a hug. And then we give her some time off to go visit with her grandbabies, and that seems to kind of reorder her world a little bit. But I think the biggest thing is that just understanding that there's going to be a smaller cadre of patients who may benefit from it. But seriously, if 1 out of 5 patients gets less injectables and a shorter treatment, you still take that, like all day. You want that, what's best for your patients. And so I think just kind of the tempered enthusiasm is more so that there are some things that we can test for, like the PZA and the thiamutol. And when you see that, the regimen works with these components. And what happens when you take them out? Maybe there is some, like the INH, when you took it out, it very clearly dropped, even though it should not have been as effective. But, it popped back up the efficacy very clearly. We did Koch's postulate with, isoniazid in and out of the regimen. And so, there's just a lot of components that are more so tied to what we're able to do here. And, again, with Nia's point, when you know something is unlikely to work, even though it was part of the regimen, then you feel kind of funny about just leaving it in there. But the regimen, as stated, was what was used. So I think that's some of, I don't really have any other original thoughts except those.
Yeah, no, it's worth, I think it's worth, tapping the brains and hearing the thoughts of the people who we think are kind of our key thought makers. There's a better term than that. the people I look to for advice, and we all have folks we look to for advice. And, what are they saying across the country? And I can say, when we sat and we saw this data in Vancouver, Diana Nielsen, so the New York person who sees the most MDR and has been doing that for years, at the start said, no way, no how, we are conservative in New York. I can't do the New York accent, though, I wish I could. And then by the end, she said, maybe. And I think the real head scratcher, Penn paused, and he said, it was when you see that like 70% of the people had resistance to PZA. Somewhere in that range, right, in some country studies, still with this excellent success rate. And I know from the original WHO meta-analysis, and new data is being formulated right now for the US guidelines, but the original said, that sweet spot of number of drugs was kind of like 5 to, in the PET study is saying like 6 range. So maybe it's just saying that, in places where you're not going to get PZA and ethambutol data, even, that you just, as long as you start with this higher number of a good mix of drugs, bactericidal, sterilizing, that even if one drops out, it's just this higher number being religious with it. And we do that, we get really great results, and then we keep treating. And if we see someone's not responding, we swap and we treat, and we're really, really successful. But if for the ones that you start and you go and everything is going well, maybe we really could be stopping this early and with shorter injectables.
I just want to add one comment, and that is that I have to say I'm a little skeptical about the phenotypic drug susceptibility testing for ethambutol and what it really means. And I think it's interesting that we don't have, no one's making a sequencing test for ethambutol resistance. I'm not sure we really understand what it does, and I know the way we use it is to protect against the emergence of resistance, and we don't actually use it to kill TB, although it does have some effect in vitro. I personally am much more a fan of the molecular testing. I think it's better than the phenotypic testing, and when they don't agree, I follow the molecular testing. But we don't have it for ethambutol, so that leaves you in a little pickle with that one. But so I don't know what to do with ethambutol, and I tend to leave it on because it isn't terribly toxic. But that's because I don't think I really know what I'm doing.
Dr. Chen, can I ask a question? I'm
sure.
sorry.
Yeah.
My name is Julie. I'm a nurse at Highland, and I believe that shorter is always better when it comes to holding your patient's hand and trying to get them through all of these medications. My question for this short course regimen is, what milestones do these patients need to meet to show that they're hitting, or that they're that they are not progressing, that they're meeting, that they're
responding okay.
Yeah, that they're responding to treatment. So
Yeah.
like culture conversion times, radiological improvement or regression of disease. What is that sort of time frame for the short course?
Well, the only one set out, I think, in the WHO recommendations is smear conversion, and so that's how the original Bangladesh regimen was constructed, that you could extend the intensive phase from 4 months to 6 months when smear conversion hadn't happened by 4 months. I would say that does not describe many patients at all that we see. Most have certainly culture converted by 4 months. But that's the only one set out by WHO. I mean, I think we would do what we do with all of our MDR patients. We would follow chest x-ray. We do it every quarterly. We would follow sputum at least monthly to make sure that culture conversion happens. And so those would be the milestones that I think I would use treating patient with the short course.